So the topic I'll be talking on is on aging among adults in the context of HIV. This is the outline of my talk. I will initially start by talking about the changing face of HIV disease in the CART era. I'd like to then briefly introduce to you the concept of functional aging in HIV and share some data with you, and hopefully convince you that we should really be transitioning from looking at chronic diseases as a focus of aging in HIV to looking at more holistic markers like geriatric syndromes, and finally to share some thoughts about how I think we could improve our understanding in the health issues of adults living with HIV from a research perspective. So I think the management of HIV with antiretroviral treatments is probably one of the greatest success stories in medicine. In just over 30 years, we've managed to change the face of this disease, which used to be a death sentence to anyone who acquired the virus, to now a chronic manageable disease. And we are still making some progress in this, and this is work from the ATCC, which was just published, where they found individuals who started treatment in the late CART era between 2008 and 2010 are still experiencing improvements in their life expectancy. However, in all the cohort studies that we've seen published from around the world, we still see that survival remains lower than the general population. So with people living with HIV living longer, we are also seeing a change in the demographics of people in the community. In studies done in developed countries like the Netherlands, by 2025, we expect 2 in 3 individuals to be over the age of 50 years. And in different cities in the US, we've already heard about how it's more than 50% in some of these cities. In the Asia-Pacific region, and this is data from the Treat Asia network, which was recently published, we expect by 2025, 1 in 3 individuals to be over the age of 50. As our patients are living longer, we're also seeing issues in terms of multimorbidity, and this is quite an old study, but it was one of the first studies to highlight the issue of the burden of polypathology in patients with HIV. It was done at the Modena Metabolic Clinic in Italy, and in this study they found that the proportion of individuals presenting with multiple comorbidities in the HIV-infected individuals was almost similar to those in the uninfected group, almost 10 years older. So I put this slide together to try to get an idea of what the issues were in the Asia-Pacific region. And though with some of the diseases, the prevalence were above 40%, but there was a wide variation across some of the different countries. And these are from papers that were published in the last 5 to 6 years. One of the things that occurred to me as I was going through the literature was that a lot of these studies did not compare the rate or the prevalence of the diseases in the country, in the HIV population, to the controls. And so you really don't know what the risks are above your general background level. So we just finished a study in our center, which was the Malaysian HIV and Aging study, and our main objectives were to look at various aspects of aging in HIV, in treated HIV patients. So our cases came from patients who were returning to our clinic for their routine follow-up, and the inclusion criteria were individuals aged 25 years and above, and everybody had to be on stable antiretroviral treatment for at least 12 months. Our uninfected controls came from community-dwelling individuals whom we had, who responded to study flyers in the same catchment area of the hospital, as well as friends and family members of our patients who accompanying patients in our clinic. All of our controls received HIV screening tests to ensure that they were seronegative. So we had 329 HIV-positive individuals and 290 controls, and out of this, 172 pairs were matched for age, gender, and ethnicity. Now, we looked at many parameters, but one of the parameters we looked at as well was the chronic comorbidities in this group. And the presence of comorbidities was ascertained by a number of sources. And in this study, we found in this analysis, which included 172 matched individuals, the median age was 42 years, and the CD4 count in the HIV group was over 500. We found that chronic kidney disease, cardiovascular disease, diabetes, metabolic syndrome, and osteoporosis were all more prevalent in the HIV population, with risks ranging from 2 to 5 compared to the uninfected control. Something that we came across which was quite surprising to us was that hyperlipidemia was actually significantly higher in the uninfected controls compared to HIV. And looking back, and this probably reflects a very high background population level in our recent National Health and Mobility Survey in our country, 1 in 2 individuals over 19 years old expected to be hyperlipidemia. The other probable reason is because a lot of our younger patients had never, or rather had never had a screening prior to being part of the study, whereas our HIV patients, although they were younger, they were already engaged in care and had already been screened and were already on treatment. We didn't find a difference in terms of liver disease and hypertension. So it seems like antiretroviral treatment has done very well in terms of expanding lifespan in our patients, but is doing very little in terms of its impact on health span. And health span classically is defined as the lifetime of an individual where it's spent with optimum health, with no disability and no morbidity. So how should we be measuring health in the setting of HIV? So at this point, I'd like to introduce the concept of functional age. And aging is really a functional capacity of an individual rather than an individual's chronological age. And like it or not, as we all reach adulthood and as we grow older, we all will start losing function. But we also see in our daily lives that there are some people who are more vulnerable to this loss of capacity, more compared to the others. And for example, we see 80-year-olds who can run marathons still versus individuals who are in their 40s and 50s who already require help just crossing the road. So 2 individuals can have the exact same chronic disease, but can have very different trajectories in terms of their functional capacity as they grow older. And this means we really shouldn't be looking at chronic disease alone as a marker of aging in HIV, but rather be measuring functional capacity or looking for ways to measure functional capacity in our patients. So we're lucky that our colleagues, our geriatrician colleagues, have already developed some tools that we can use to assess this in our patients. Geriatric syndromes, are also sometimes called aging-related syndromes, constitutes a number of tools which measures different deficits in different health domains, ranging from functional ability to nutritional state to cognitive function, including socio-environment as well. And geriatric syndromes generally occurs as a result of accumulated deficits in multiple organ systems that then renders an individual vulnerable to situational changes. So our geriatricians use these tools. Generally, they measure all of them, and collectively it's called a comprehensive geriatric assessment. And they use this tool to give them an idea of the overall functional capacity of an individual. Another key defining feature of geriatric syndromes is that it's multifactorial, and this is what leads to its complexity. Often, and this is an example of 2 geriatric syndromes and the different etiologies that can potentially lead to its occurrence. Many of the factors are interrelated and they compound one another. Geriatric syndromes tend to co-occur. One, when you get one problem, it always then leads to the development of another problem. And so management of geriatric conditions, once it occurs, is quite hard. And the best way to approach this is really screening and prevention. So in the same cohort that I introduced to you earlier, we also performed comprehensive geriatric assessments in all of our patients. We looked at different domains. We looked at cognitive impairment, depression, malnutrition, vision, polypathology, polypharmacy, urinary incontinence, gait abnormalities, frailty, and difficulty in IADL. And we then computed a burden of geriatric condition in our patients as a composite score, ranging from 0 to 10, depending on the number of conditions the patients had. We also then looked at health outcomes. We looked at mortality risks using VAX index. We looked at healthcare utilization, where we asked the patient to recall the number of healthcare visits they had to any facility in the prior 12 months. We measured quality of life as well as self-rated health. And we compared the prevalence of these conditions in the 172 patients who were matched for age, gender, and ethnicity, and the median age in this group was 42 years. So looking at the prevalence for all the 10 conditions, what we found was that the prevalence was numerically higher in the HIV positive group for all the 10 conditions that we measured, and this is shown in the open bars versus the age-matched controls in gray bars. We also then looked at the proportion of patients presenting with multiple geriatric conditions by age group, and we found that the proportions were significantly higher in the HIV patients compared to the matched controls, even in individuals in their 20s and 30s. We then looked at how these conditions, or the burden of these conditions, were associated with quality of life. And you see here in this graph, in the y-axis is the score for quality of life, and the x-axis is an increasing burden of geriatric conditions. And in both groups, as the burden increased, your quality of life scores declined. But in the HIV group, the decline was greater compared to the uninfected controls. And on average, we found that the quality of life scores were 2.5 times lower in the HIV positive compared to uninfected controls. We then looked at healthcare utilization, and as the burden increased, healthcare utilization in HIV-infected individuals was 5 times greater compared to the uninfected controls. And then we looked at mortality risks, and the mortality risk was 4 times greater as the burden increased in HIV patients compared to uninfected controls. We also then explored the risk factors that were associated with an increasing burden of geriatric conditions, and both clinical and social behavioral factors were important. In terms of clinical factors, low CD4-CD8 ratio, and a history of AIDS-defining illness. In terms of social behavioral factors that made up the bulk of the risk factors, education level, employment, alcohol consumption, low physical activity, increased abdominal obesity, and social isolation. So in summary, increased life expectancy in HIV is accompanied by a high burden of functional aging, even in young patients, young treated patients in our setting. The increased burden of geriatric conditions had a significant impact on health outcomes, including mortality risks, and both social behavioral and HIV-related risk factors contributed to this increased burden. So the significant implications here is in terms of how we manage our patients, and I think we really need to start thinking of multidisciplinary team approach. And these were essentially young patients on treatment, doing very well on treatment, and they were still experiencing quite a bit of issues in terms of how they dealt with the stresses in their daily life. So how do we go from here? And I just want to share with you some of my thoughts from the challenges that we faced running this study in our center. So this table summarizes some of the geriatric syndromes that have been measured in other cohorts and other larger HIV cohorts and been published. And although the list is not exhaustive, it's enough for me to make a point that very often geriatric conditions are assessed as a single entity. And the nature of geriatric syndromes are that they often co-occur. And so when you measure its occurrence as a single entity, it gives you an idea of the breadth of issues that the patients may be experiencing, but it doesn't allow you to appreciate how each condition may interact with one another and finally be associated with health outcomes. So far, there are only 2 studies that have looked at comprehensive geriatric syndromes. One is in a UCSF cohort, and the others was in ours. So I think we need more studies in terms of, more studies which assess multidimensional aspects of aging rather than single domains. And the other issue is that a lot of the studies that have been published previously have been in individuals 45 years and above. And I think if you're looking at functional aging, it can occur at any age. You can be depressed at any age. You can have cognitive issues at any age. And we really need to start looking at the issues in our younger patients. We need to start including health outcomes as endpoint assessments. And these are non-standard medical assessments like life, quality of life, self-rated health. And these are the indicators that is going to tell us how our patients are doing in terms of dealing with daily stresses. The other challenge that we faced in doing this study was that the assessments for geriatric conditions are fairly subjective, and they often use tools that are questionnaire based. And a lot of these are validated not for the developing country setting or the Asian setting. A lot of them have been validated in a Western population. And so as more and more studies within this region start looking at geriatric conditions, I think it's useful for us to start thinking about how we can harmonize some of the definitions so that we can compare rates across. And finally, as we found in our study, the social behavioral factors were really the big drivers for geriatric conditions, and we really need to start looking at this more in detail. So as we realized that just looking at viral loads and CD4 counts are no longer enough in terms of managing our patients, we need to start thinking about how we need to incorporate different services from different expertise. One area that I think is going to be very challenging is working out which model of care is going to be best in terms of delivering all of these services to our patients. And that's probably going to be very country specific because it depends on the resources, it depends on each country's health framework and so on. So I have a huge team of people to thank for all the work that has gone into doing this project, especially the co-PIs who are the sub-project leaders, and the lead leader in this project, Prof. Adiba and Prof. Sharul. Thank you.